Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Well, welcome everyone to another episode of The Pursuit of Health. I'm your host, Rainier Schur, and joining me on the show today is Dr. Tina Marsh Dalton. Welcome to the show, Tina.
Thank you for having me.
So, Tina, you are a professor in health economics at Wake Forest University. But the way that I first came into contact with your work is through your Substack,
Mm-hmm.
Words to the Why of Healthcare. And
Yes, and I like to say why is WHYS because it's already funny.
it's already funny. And also, I sometimes when you say the name of your Substack on podcast recordings, you say the why with an exasperated why, which
Oh
I think
yeah.
is funny too.
Yeah,
And
because that's where I feel people are very frustrated, and I want to help with that.
yeah, and that's kind of how I situate your Substack as well, is that there's a lot of frustration about the healthcare system. But then very often the kind of why, the explanations that we get are kind of knee-jerk or simplistic. It's people blame the profit motive, even people that are more like pro-free market, they're like, well, it's the government, but then like they don't really explain like in detail like
Mm,
what's actually really going on. And so that's why we're having you on. Like we want the words to the why of
yeah. I also like to think that all the different agents working in this system, that so many of them just they're there because they want to improve health, and it's just the structures around them are not helping them. So it's less of a conversation about whose fault it is and more about what is the structure that is working or not working. Because we could all just get together on we would like health to be better.
right. And it's definitely the kind of approach that we try to take with this podcast as well. It's not like
Mm,
blaming individual actors, but looking at the overall infrastructure of the system.
yeah.
But speaking of blame, one kind of party that's being blamed quite a lot these days are health insurers, right? And
Mm,
so
yeah.
I even find myself like asking all sorts of questions of why are they acting like this? And I'll just give you a brief personal example. So I sometimes get medical bills in the mail from my insurer, and it's an explanation of benefits.
Hmm.
And very often when I get those things, I get like a moment of panic, like, oh my God, am I gonna get like a really big bill? And then very often it's like, no, it's like just an explanation. It's like $0 or like $20 or something. And then I just forget about it. But sometimes I'll actually look at the actual explanations. And it can go from, wow, I'm really impressed they managed to negotiate this way down. And at other times I'm
Hmm.
like, you only negotiated it down this much and you still paid this much to the provider? And like
Yeah,
I'm
the
thinking like,
numbers that are on those explanation benefits kind of are all over the place, and they blow your
yeah.
mind about the amount that is being charged for what seemed to be a small thing.
Yeah, and so that takes me to my first question, and I guess it's two questions because whenever I see those explanation of benefits, I think, wow, like if only I knew that this provider was going to charge the insurer this much, I would have shopped around. And like, why
Mm,
couldn't it be the case that like my insurer could do more work to like help us shop together, and like we could like both save money, and like that could lower my premium. So like that's like on the individual level. But like on the macro level, like why aren't health insurers better at keeping costs down? Because they keep increasing over time, and I guess those are kind of related.
yeah, the healthcare costs have been increasing faster than inflation for quite a long time. Um, I think there's maybe two big things to talk about why can insurers keep the costs down. One is the structure that the insurers are in, and then I think one is even that's already pretty big, but even bigger than that is how has healthcare evolved over time. So um, let's start big and get smaller.
Yeah.
So the how health has evolved over time when we think about our system or really any industrialized system, which is why I like writing these bigger structure ideas because it's not just the US struggling with this. We're double the cost of Europe, but we're having the same problems as Europe. It's just our levels are different. The prices are rising. People aren't getting that much healthier. So one thing that's different about where we are now is that when the healthcare systems were set up hundreds of years ago, it was mostly focused on acute needs.
Mhm.
So infections were killing us. Those are acute. You fix the infection, and then we can move on with our lives. Other acute things, we started to move into cancer, but that was sort of an acute problem of we need to address this attacker that's happening right now. But where most of our killers are these days, the top one is heart disease, we've got diabetes, we've got strokes. All of these have this chronic preventive component to it. And the system was set up to deal with acute problems. And the way that we often deal with the chronic problems is still treating them like acute. So diabetes, type 2 diabetes, you get it after many years of insulin resistance. So this might happen through lifestyle, it might be happening through diet, but we don't treat it until you pass some threshold, right? Like you're not diabetic and now you are, right? And so we have all these treatments, but what really would have saved costs in that case would have been intervening over a 10-year period earlier. But the system was not set up to kind of do any of these things. And it's not profitable for the big interest groups to do prevention, because if you prevent a patient from getting type 2 diabetes, then you don't get to reap the rewards of all your type 2 diabetes treatments. So now we can move into the second piece is now I'm an insurer faced with this problem that the healthcare system is set up really well to treat acute diseases and not so well to treat the chronic diseases, which are more of our problems these days. So, well, what could they do about it? Well, one problem is that in the US, the way that we consume insurance is usually on a year basis, or maybe even over a few years, right? You sign up through your employer and you switch off if the employer changes your plan. But this means that the cost of prevention always hit before. So if I had interventions on lifestyle, on diet, and tried to have just sit and talk, this is doctor's time that really isn't reimbursed very well. I put all the costs in to pay off in 10 years. But in 10 years, my enrollee might be somewhere else. If I'm on the exchanges, they can pick a new plan next year. If I'm in employer-sponsored insurance, which is about 50 to 60% of the US population, the employer might just change plans, or the employee might go to another employer. And so all the work I did to pay for the costs of prevention is going to get reaped somewhere else, maybe by my competitor. And so we have a bit of a problem that the insurers themselves, if they take on the cost, they're not able to reap the rewards of it. And then we're going to layer in one more thing. So I'll add one more, which is I have a scary picture of type 2 diabetes in particular, which onset of that is usually around 62. It peaks around 80. In the US, if you are 64 years old and you get type 2 diabetes, what's going to happen next year?
Medicare.
You're going to be on Medicare, right? So all these private insurers, they could prevent these long-term chronic diseases, but not only will they pay for it, but like the government's on the hook for all the problems that would develop afterwards. So this particular study where they had a picture of prevalence of type 2 diabetes was particular to New York City's ER visits or something, but it peaks around like 70, 80. Well, they're squarely at a government problem at that point. So why, I mean, you can easily see why insurers would not put much effort into preventing these long-term old age diseases when they're never going to have to pick up the bill for it.
And so in that sense, would you say that there's something to the narrative that we have a sick care as opposed to a healthcare system? I tend to kind of wince at that because usually people say that to like impugn the profit motive as such, but then I look at things like this and like, well, yeah, maybe it is, but it's not the profit motive. It's all these incentives that really does push people away from value like preventive care and more towards acute care.
Yeah, the system as it's set up doesn't offer any way to capture the benefit of making people healthier. Individuals might capture the benefit, like if I'm healthier, I will feel better, but I won't see any change in my premiums.
Right.
Because premiums are as in the most dominant market. Well, now even in the individual exchanges, there's almost nowhere in the healthcare system for medical insurance where your insurance is going to be priced according to your healthcare status. This happened after the ACA, and it was popular because this is where norms and morals come into healthcare, where they don't come in other areas of economics, perhaps, in that, you know, what is fair in healthcare and what was an unexpected illness. Cancer has some preventive component, but then it has some uncertainty. What is fair, what was unexpected? So pricing according to you have a chronic type 2 diabetes that wasn't prevented, some people might find that it's a bad incentive that you don't reap the rewards of preventing it. But then some people might view, well, there's a lot of genetics and this is luck. And as a society, we want to take care of people that have bad luck, which that's not a bad norm. I'm
Mhm.
happy that to live among people that would think that, but it sets us up in a difficult position about how do we incentivize people to be healthier, because it's not, if I get healthier, I pay the same premiums that I always did.
Right. This is group-based insurance.
Yeah, the group-based insurance. And there's no part of the formal healthcare economy that gets a benefit from me becoming healthier. In fact, there might be some that lose out, right? So if we
Mm.
suddenly get really into exercise and healthy living and no one has type 2 diabetes, well, this is going to be a big hit to some pharmaceuticals bottom line. But yet, if everyone does, everyone's healthy and able to do their jobs, employers would benefit, individuals would benefit, but that's not a concentrated group that can reap it.
Right. And the other end of that exchange, because like we're talking about fairness, is there also a danger that you're kind of getting rid of like the incentive to innovate in certain areas?
Yeah, I think that when we're all thrown into the plan for everything, so I have another piece I write about frequently on my Substack, the idea of insurance should be there for uncertain things. That is the original role of insurance. And when we act like it's our discount plan, that we end up throwing a lot of things that are not uncertain, like chronic disease pills, glasses. We throw them in, and then they're sort of mixed up in this insurance monster, which can hurt innovation. So if you think, my favorite example to explain this idea is thinking about like things that you need medically. Usually people say, well, they should be in insurance. If it's a medical need, that means insurance. But insurance and healthcare, they're not the same thing. So if we think about on dental care, what if our toothbrushes were part of insurance, right? That we need them. You need it to maintain
Hmm.
your health. But I think we could all imagine what it would look like if toothbrushes got thrown into insurance, right? First of all, the insurer would tell you which toothbrushes to buy. Second, because you're not paying, they would become very expensive. Third, we wouldn't have all this choice, right? And I wouldn't be able to go pick them up whenever I want. I'd have to get some prior authorization if I lose it while I'm on vacation. Like, it's just a mess. So these things that we throw into insurance that maybe don't need to be there, we're going to hurt. There's a lot of innovation in the toothbrush market. My brother's a dentist, and there's all kinds of different, like, you can have these electronic things, and some are more effective. If your kid doesn't like brushing their teeth, there's like cool ones with their favorite superhero, right? So much variety, consumer preferences, you can judge quality. There's also access issues, right? Because if we put them in insurance, how would people who don't have access to nice insurance get them? I think people leave that piece out. Innovation could be we develop even better versions, but innovation could also be we develop a cheap version that people can actually afford.
So it seems to be that there's all sorts of ways in which people's view of like what ideal health insurance is gets in the way of all sorts of other things that we might want, like access, like
Hmm.
um, variety, like convenience. But what would a more ideal conception of health insurance look like that doesn't have those things, but then you can at least tell people like, okay, like not everything's going to be covered, but here are all the other good things you're going to get from this other version of health insurance.
Yeah. So I can think of some dream worlds that I would like to see. One that could combine maybe with the prevention. So first, we would pull out things that don't need to be there. So this would be anything that is certain and not expensive. And I think that's hard to think about because, for example, my favorite thought exercise is like insulin for type 1 diabetics. So my mom has had type 1 for now 45 years, right? There's no uncertainty. Like it is frustrating to her that there is no uncertainty, but there isn't. But if she wants to consume it, it's in her insurance. She actually kind of ridiculously has to always be reapproved to
Mm,
get insulin.
that's annoying.
Like sometimes she's like had it longer than the person approving it has been alive, right? So it's very certain. But if I say, oh, let's just take it out, right? People would freak out, rightly so, because it's currently in the monster, and there's only three producers of insulin in the whole United States, even though it's been generic for 100 years. And so it's in this monopoly machine, and everything's expensive. But if we could pull out, maybe we start smaller, right? We start with chronic prescription drugs, Lipitor. It's not expensive to make. It's not uncertain once you've gotten this diagnosis, and it could be cheap and accessible. So pull these things out, and it's just there for that. You just have things that are really big and really uncertain. So that's like cancer. We don't take cancer out. That will wipe you out if you get it. You're not sure you're going to get it, but if you do, it'll be a problem. Those are the kind of things we want. We pull the other things out. Like my mom could go to a CVS when she's on vacation. She could refill. She wouldn't have to wait. Sometimes when there's insulin shortages, it's really rough because if she can't get the approval back in time, her supplies are running low. And it's all dependent on the insurer just controlling this. It would also be if you don't have access to really nice employer-sponsored insurance, you could go and you could buy it directly because it would be cheaper. But the prevention component, because this is all nice, let's just take stuff out, right? But we do want to be connected maybe into the healthcare system to monitor our health. So I've been playing with lately the idea of when I was pregnant, right? There's kind of two ways you can deal with a pregnancy in the United States. It's much more common in the US that you're with an OBGYN, right? They have an advanced medical degree in obstetrics and they're going to take care of you. But it's more expensive. They're also probably more likely to do a C-section because they're high risk. There's also another line that you can take, which is midwifery. This is common in the UK that you just always go to a midwife, and they don't have as much training, but they're trained to deal with ordinary, healthy births. So if there's something complex, they're going to refer you out. That's like, above their pay grade or something complex, you go to the really specialized person. But if you don't need the specialized person and you just want to stay healthy and keep everything on track, you can be with the midwives. And so this is the route I did, of course, because I read too much medical literature and I was like, I had to search them out. But why don't we have something like this in sort of more general care? And we used to really in terms of primary care doctors, but I think they've been forced into a system that focuses on acute care, right? But if you wanted to maintain your health, why aren't there two paths? There's the ordinary path where they could do things like sit down with you, talk about lifestyle, talk about diet, work with you. I think about this with my mom too, because a lot of maintaining your type 1 diabetes is just annoying stuff of like remembering how many carbs are in everything, keeping track of your patterns of when do my blood sugars get low or high, what does exercise do? And all this just kind of like, it's just like an annoying, like if you've ever tried to be on a diet, right? You got to look at your lifestyle, figure out how you can work in things that are going to make improvements. It's not like a prescription, right? It's per person. And so someone sits down with her and just works through what's working for you now, what's not, what can we tweak to improve it? Oh, you're getting tired of doing this, or all right, what can we do to motivate you? Right? All this is really time consuming, but does not pay any pharmaceutical company anything. But if we had two tracks, one where they could specifically be paid for doing that, and then if something like diabetes got out of control or something, then you could refer them to the other track, and that would be the expensive track. Maybe that would have higher premiums. But two tracks, one which could really focus on maintaining the health and the providers would be rewarded for that versus treating problems once they got big enough.
But so part of what you're suggesting then is that for especially the less acute track is that people shop more around for their healthcare. And with
Mm,
something like prescriptions, I think that is probably more intuitive for people because people shop around for other products. But I think that there's still kind of like a cultural barrier for both patients and doctors of
mm.
the idea for shopping for the rest of healthcare, because then they think that, well, that's a doctor-patient relationship. Like that doesn't belong in the commercial realm, or at least not in the same sense that like pills or whistles or other things that I can buy in a market.
Yeah, because the advantage or the mental, there isn't much a mental space with the pills because it's
Yeah.
a thing that I
Yeah.
buy, just like Amazon's trying to get in that game too, right? It's a physical thing, whereas these services, physician services, are not a physical thing. But we do spend our time buying services in our life, right? When we need to repair our home. Um, the problem is information about the different physicians. I think this is where trying to imagine the world would be
Mhm.
useful. because the world that we're in right now, there's not much chance to shop around or be informed about physicians. So I'll give the experience that I had with the midwives that I was like 100% on these were amazing midwives. Shout out to them in Winston-Salem. But when I was first looking, they actually sat with me for an hour and talked to me for an hour
Mm.
about kind of what they normally did and what the process would be. And I didn't know much about being pregnant. I had never been pregnant, and they were laying out what the process would be and what normal trajectory were, right? All this and for an hour. It was just mind blowing that a medical professional would spend an hour with me. The reason they could do this is that they are not as expensive. Like the insurance company and the health system paying them doesn't pay them as much per minute, and so they can take the time to explain things. Um, it's hard to imagine that in physicians. Like, could I sit down and just get to know a physician and understand whether he would be a good fit for me and my family and the goals that we have? The physicians right now are being forced to churn people through at such a fast rate. They have to see patients every 10 minutes. And so it's not surprising they don't have these conversations because it would really hurt their bottom line to do it. Sometimes, since I'm a faculty, right, I teach undergraduates, and I feel some of them maybe have parents that are physicians, or maybe they want to be a physician. And I emphasize, I do not think that physicians are just out to fleece us all, right? We're
Mm.
looking at the incentives that they're facing, and what kind of a hit do they have to take to their livelihood to try to do this kind of care? Right now, they are in the acute churning system. And so it's hard to imagine a time where they would have availability. We could meet with them within 2 months and we could sit and talk and find out if this is a good match for the different health goals that we have.
Right. Because from what I understand, if, for example, a primary care doctor in the insurance-based system goes to DPC with a smaller panel, for the first few years at least, they might end up making less money. But what they
Mhm.
gain in exchange for that is more time, more meaningful relationships. So, like, uh, not all the benefit might be monetary, but like, there's other things that are important,
Yeah, for
right?
the physician. Yeah, and that I've written a post a little bit about this idea of concierge care,
Mhm.
about how it could be great. And what makes me think of it is two physicians that I had here in town that I thought were really great, did a great job listening and working through things. They both left the practice and they
Mm.
both went to this new concierge practice, which was concierge care, if your listeners aren't familiar with it, but it's the idea that you can pay into a special practice and they focus in on availability, that you're going to be able to get seen very quickly. They're going to spend more time with you. They do extra testing. So if you have health goals of improving your fitness or losing weight or monitoring your diabetes, heart disease, there's they kind of spend more time monitoring it and coming up with plans versus, you know, eat your Mediterranean diet and come back in a year, right? They'll test you more often, see what the progress is. So this all sounds great, and this sounds a little bit like this other alternative plan that I'm suggesting, dreaming of. Uh, but the problem, at least with the one that was in town, they don't even list what the price is. You have to call up and ask. So, you know, just like the lobster on the menu that just says market price,
Right.
like you better be ready to pay up. Don't even bother asking. So it was very expensive to join this practice, and I think that's what one hitch of holding up this beautiful dream I have is that it's on top of what we're already doing. We've got a system focused on acute, that's very expensive, and there's no way to opt out of that and choose a different path. You have to do it on top of the existing expensive path.
Yeah, another component of that, it seems, is that if we're asking people to shop for healthcare in a system that was not made for shopping, that's
Mm-hmm.
pretty terrifying. And so
Yeah.
you're really kind of like stuck in a cycle where in order for the system to become more shoppable, more people will have to do it. But in order for more people to have to do it, it has to be more shoppable to begin with. So like some brave people like yourself have to actually go out there and like ask questions like show me the price and then the actual providers will respond. How do you think we can break that cycle? You just have to have more brave people or what kind of role can economics play, for example, in like trying to break down that barrier?
Yeah, so that was the big idea of these HSAs and these consumer-driven health plans. So if anyone has an employer contributes to a tax-deferred fund for them, that's the HSA. And the idea was like, well, just give the money to the consumers and they'll do the shopping. But then you find out no one knows the prices of anything. One seems like positive development in that is the new hospital price transparency laws that were passed. They have a list of services that hospitals need to make publicly available, what their prices are. This is already messy, right? Even giving the example of giving birth, of course, there's not like a giving birth doesn't always happen as you expect, and there's all
Yep.
these different outcomes that could happen, and so they try to give a price, but there's a price for every scenario, and asking for one price is hard. It's a step in the right direction. I think this can improve several ways when we talk about improving competition and the market. So when hospitals, they don't like putting these prices up because it's part of their strategic bargaining with the insurers. And so what they have exclusive contracts. Every person that walks into a hospital is going to be paying a different price through their insurer, depending on what the secret bargaining is that is not public information. But opening that up could make all the forces move better. Because the other thing, again, being thinking that doctors and providers really want to make health better and they want to be doing good things in the system, but they don't know the prices either, right? So if you ask your doctor what's this going to cost, first they don't know that average cost. They don't know what it is for your particular insurer. So they can't make good decisions. When we think about economics, we should be making decisions understanding the costs and benefits. And now the providers choose it according to the benefits, the insurers choose it according to the costs, and no one's talking to each other. So making it more like a market is, I think, scary for people because they say, well, market-based healthcare doesn't work. Look at the US, right? But I look around and I'm like, what if we consumed what if we consumed movies like we consumed healthcare in the US, right? You go to the movies, that someone tells you which movie you're going to see. You go in and you see it. You only have a set list of movies you're allowed to see, and then you leave, and 3 months later you find out what it costs. Like that's not a market,
No.
right? So where in the healthcare system is the market-based healthcare? Because none of that is a market when I have no idea what the price is, and I won't find out till later. So being scared of a market, I don't think what we have is a market. So prices are so important for making good decisions at all levels. The more we can open up prices, the better decision making we can do.
Another component where I kind of see the current healthcare market as being stuck is not simply it being a scary prospect to ask patients to shop for healthcare, but the fact that so many people's jobs and like narrow financial interests are kind of tied up with the status quo.
Mm.
And like if you try to like move one piece of the uh Jenga piece or whatever metaphor you want to use, like someone's narrow interests will be threatened.
Hmm.
What would you say to like someone like who's like running an insurance company or something like that that well yeah, like there might be short-term losses, but long-term like a market reform isn't going to be like necessarily like less profitable.
Yeah. So that is maybe something that people that want to fix healthcare, we should be talking more about where are the benefits and how can they be shared. Yeah, so when we talked earlier about the benefits of becoming healthier, just go off into the ether, right? And I'm
Mhm.
not sure I'm thrilled with the idea of there should be a Weight Watchers lobby that is big enough to offset the pharma lobby.
But it's something along the lines of, look, guys, there's so much uncaptured value in the
Mhm.
market that, like, for example, insurers don't get to benefit from, but they might not care because their competitor can't benefit from it either, right?
Yeah, that's true. I wonder if there's more about there's because we're set up for acute needs, right? You get in like car accidents. Healthcare system does a great job with that, right? But those are so short. Um, Another idea is that I think the US is optimized over too small of a window, that we need to open this up. When people say that they want universal insurance, there's some level where universal insurance makes sense with this problem, right? I don't need to be insured against type 1 diabetes within this year, right? Or my mom doesn't because it's not uncertain anymore. But I don't think that's the uncertainty we're actually all worried about. I'm not worried whether over the next year I develop heart disease. It's from age 20 to age 60 I'm worried about where does that path lead. So you don't expect to get type 1 and then you do, and now you're shifted onto this expensive sickness path. And I think that's the real uncertainty we got. So, of course, universal healthcare does this better in that if you're like there from birth to death, it's all within one system. But it might be that there's space for more like this life insurance level of time. That if I sign up with an insurer and I'm healthy now, but I'm going to be with them for 10 years, they are quite happy to keep me healthy for 10 years because I'm going to keep my costs down for them. Within 1 year, they're not interested at all.
Right. So your pitch to like a health insurance CEO could be something like, I know you're geared towards all this acute care, but imagine how much more competitive you could be if you can pitch your products to care for someone's health for decades and not just whenever they like need to be admitted.
Yeah, if you had a 10-year contract where the costs were pretty low because you're just having the doctor talk to the patient once or twice a year, and then you have a guaranteed premium flow for 10 years, it would be a different model for sure. But there could be a way where that's a nice, secure, profitable model. I think another piece that we haven't talked about yet that is really important for our system and related to the dissatisfaction, but also related to no one's reaping the benefits, is that the US system, insurers don't actually have a relationship with the patient. It's so this sounds crazy, right? You get all these mailings and you're confused about them. But the dominant insurance, so all the biggest categories of the way people are insured in the US. Number one is employer sponsored insurance. This is about 164 million people.
That's what I have.
Yeah. And number two is Medicare. That's about 65 million people. And then Medicaid. Um, let's pick the smaller Medicare. So this is the elderly insurance. The patients covered under Medicare, they are not at all involved in designing this healthcare system because the government designed it. Now we do have this Medicare Advantage where you can choose, but let's just on a broad level, the government is determining it and you just enter it or not. The other part, employer-sponsored insurance, which is 2.5 times as many people as are on Medicare. This is through your employer, but thinking about what's the relationship between the patient and the provider? So backing up to what is insurance in the first place? If you're going to buy an apple, right? I am the hungry person, there's a farmer, and I can pay them directly. We don't do this in healthcare. Now, there's good reasons we don't do this in healthcare because of that whole uncertainty thing. And if I get cancer, I want to know that this would be taken care of. So we introduce what they call the third party payer because it's the third party. It's not the patient, it's not the provider. The insurer is going to manage the payments. So I'm going to, instead of paying the provider, I pay the insurer and the insurer pays the provider. Now, that's how it works in, say, the Switzerland health system because they're all just choice based. It's kind of like our exchanges. I go out. It's also maybe working like this a little bit in Medicare. I go out, I find an insurer I like. I pay them, they pay my provider. If I don't like them, I leave. I pick a different insurer. So that's the money and the choice flow both from the patient to the insurer. They have a direct relationship. I'll give an example of Germany, which has an employer-sponsored insurance system, just like us. So the way it works in Germany is the employee chooses from a lot of plans. The employee chooses the insurer, and then the employer is just the funder. So both the employee and the employer are paying money. There's a third intermediary, which is kind of spreading the funds out. But my choice and my payments both go directly to the insurer as a patient.
Mm-hmm.
Now, the US, we have employer-sponsored insurance. But we've like switched the relationship in a way that is very detrimental to anyone benefiting from the patient being happy. So I get insurance through my employer, but I am not choosing my insurer. It's somebody in HR is choosing it. which in my in my post I talk about Dwight Schrute and The Office, and hopefully your HR department is better than Dwight Schrute. But the HR department is choosing it, and even if they have your best interests in mind, it's the best interests of 10,000 people, 5,000 people all at the same time. And I pay the insurer, right? I pay premiums, but my choice is not involved. The choice has been transferred to the employer who also pays the insurer. So I think I wrote something about it. So we feel like we're screaming into the void, like we kind of are, because there's no financial relationship between the insurer and the patient. So if I get healthier and I'm happy with my insurer, I have no ability to communicate that through choice.
Hmm.
And if so it goes both ways, right? If I'm unhappy, there's nothing I can do about it. I'm still going to stay enrolled. It's all depending on the HR department and whatever the relationship is between the insurer and the HR. Or if I love it, HR can still take it away. So they're going to choose, we're going to also assume the HR faculty are trying to also be helpful. We'll assume everyone's trying to be helpful. But the problem is they're choosing for every single person in the firm. And so if someone has some benefit, they can't communicate that through their choice. Because if we're going to talk about markets, prices, we need to know what things cost. And choice is so important to markets because it communicates very effectively whether the insurer is delivering what people want to buy.
Yeah, in the Netherlands where I'm from, we have nonprofit health insurance companies, and yeah, like I had to have my insurance cover a particular medication, and my insurance didn't, so I switched. I mean, you can only switch once a year because
Okay.
they want to prevent people from shopping too much. But
Hmm.
at the very least, I had the option. Whereas right now, I'm under my wife's employer health insurance. They switched the health insurance that we were under last year, and like we had absolutely no say.
Yeah. Yeah. And the reason that the advantages of this system for insurers are to control the problem that's always there of adverse selection. So when you're describing, oh, they don't have my prescription, I'll just switch to one that covers it, right? So the idea of adverse selection is people that like insurance, well, those are sick people.
Yeah.
And so you're more likely to get sick people in a plan, the costs go up, this is bad for the insurer and the premiums. But if you impose some limits on it, so it sounds like the Netherlands imposes limits of you can switch, but only one time, and then you're done being an adverse selection problem. Like we're shutting you down. In the U.S., the employer-based insurance helps a lot with that in the sense that we've explicitly taken away the choice. So there's no way that you selected into your wife's plan because of some medical condition. That was just like you were plunked into it and it's not related to your health at all. But taking away that choice also ruins all the incentives to reap the rewards of prevention because I would love to sign up for an insurer that ended up making me healthier, but I have no way of rewarding that in they can't reap the reward of me enjoying that.
And so is the German model then like a better one for kind of like balancing the risk of adverse selection versus more choice for the employee?
Yeah, so the German system, because of course they're dealing with that too. All of these issues we talk about, it's not just a problem with us. It's like this is a problem that's always going to be present, and we're going to have to figure out what to do. So Netherlands shuts it down, doesn't let you you can choose, but like not so much. Uh, what Germany does is that employees choose from their sickness funds, their nonprofit insurers, and then the money is put into a pool. The government will then look at who sorted into which sickness fund. And so if one sickness fund happens to end up with a bunch of extra sick enrollees, the government reallocates funds. So there is an important role for the government in their system, and that they look at the outcomes of the adverse selection and they manually adjust the money that was paid to make up for the plan that got an extra amount of sick people. So the way I could see trying to do something like this in the US might be something about like in a local area. What if all the employers in the local area, employees could choose from a centralized exchange, and then there's some reallocation of the premiums within the exchange, something like this. at a whole U.S. level, one problem that is unique to the U.S. is how big we are. So some of these things that work at a small level, trying to blow them up can be overwhelming. But I could see this working on local levels that within the same region, because we also differ in our health conditions and needs and provider availability by region. But if we controlled for that, then it might be a little bit easier to implement.
Right. I think in one of your articles, you kind of broke down all the ways in which the patient doesn't have any choice. And like one of them, which I haven't mentioned yet, is that you can't sell insurance across state lines. Right. So like
Yes.
that's another one where like, yeah, like you think that there's like some option, but there really isn't.
Yeah. So, and what I think some people don't understand either is we think about how many insurers exist at the national level. You can't sell across state lines. So, if you've heard of Blue Cross Blue Shield North Carolina, right? It's not the same as Blue Cross Blue Shield New
Totally
York.
different.
They're not, yeah. And then, but even within a state, so on the exchanges, it varies by your zip code what you have available. So we're narrowing it even further. And I remember I was giving a talk in the mountains of Southeast Virginia, just a couple hours away. It was foggy, like I couldn't see when I was going. It's very, very difficult rural area to get around. And I was going to give a talk on insurance. And the day before I showed up, all insurers had pulled off of their exchanges. And so they were very interested in my talk. They were very engaged. And
Wow.
because it isn't the rest of the state of Virginia, the DC area, I'm sure had plenty of insurer offerings, but this was a region that had worse health outcomes and all the insurers pulled out. I think what happened later is the governor leaned on some insurers and like forced political favors, and they got some choices again. But the amount of choices that exist for an individual person in the US is often just one.
Right.
It's whatever. So the statistics I had from Kaiser Family Foundation of 77%, and that probably varies from year to year. This would have been in the past 2 years of employers only offer one plan. So we've got a multitude of insurance companies and plans that exist, but any individual person might only have one choice.
Right. And we've touched on like a few potential solutions to that, but what are some other solutions that we could pursue to give patients more choice?
Yeah, so our beginning of choice was the exchanges.
Mhm.
There's been I don't know if you call it success or not. I think it depends. Maybe it's glass empty, half full. It depends on your personality. But we before the ACA set up these exchanges, we were at 16% on insurance, and now we're at 8%. So it's not zero, but it is only eight. I don't know. Audience can decide whether they think that's enough or like good or bad. Uh, so that they've increased choice. One thing that was great is they standardized plans. I think that helps with choice. I think it sort of tampers down the problem of individual sick people really getting to take like to adverse select to increase costs while the healthy people leave. Like if there's only so many choices, you can only do that so well.
Mhm.
That's good for insurers to have average costs they can more predict. And we were talking about like, do we want to support insurers or not? Like we do want to support that they have a business model that lets them continue
Right, because we
making.
need insurance.
Yeah, if we
Right.
want insurance, let's think how we can make it possible for them to offer it. Um, so that was all good. That certainly increased choice. There's more stability in those markets. But one problem with those markets is that ordinary people wouldn't move on to those markets because they are twice as expensive as anything you would get from an employer. Part of that reason is the employer is quote unquote paying part of it. You might be losing some salary, but they're paying. But the other piece is that it's tax exempt, and all these exchanges aren't going to be tax exempt, and so they're very expensive. About 90% of the people on the exchanges were being subsidized, given this latest brouhaha about should we get rid of them. So something about the tax exemptness is also hurting our ability to allow people to flow across different options in the US.
Right.
So I don't know if that means it probably doesn't mean trying to take away the tax exemptions from employers because that's pretty entrenched and lots of parties like this, but maybe tax exemption into the other choices that we could choose from. So the
Right.
exchanges would become more a viable option if they were also tax exempt.
Right, something like tax equity for individuals to have the same tax benefits as employers, or some other kind of portability
Yeah.
of the insurance so that you don't penalize individuals over employers. But one thing that I do notice, again, about the Netherlands, our plans are quite standardized as well, and like they'll differ into small things, like for example, whether they cover my medication or not. But I think one
Mm-hmm.
reason that they're able to keep costs down is that they do impose pretty strict controls. So like I have to go through everything through my primary care doctor. They read like a particular manual, and like if I fall just outside of a particular metric of what the government will reimburse, well then they won't refer me to a specialist.
Mm-hmm.
So do you think something like that would be required to make something like the exchanges actually more affordable, or is it possible to
Mm-hmm.
make it affordable while still like retaining the ability for patients like me to not have to like go through my primary care doctor in order to see a specialist?
Yeah, that's an interesting idea that the idea of restricting choice, that's what ensures their most unpopular
Right.
moves, right? The prior authorization, that's all in the name of restricting choice when they deem that the benefit is not worth the cost.
And I could accept that restriction if it were the case that, oh, in exchange for that you get a lower premium. But in the case of the Netherlands, it's illegal for me to go to a specialist and offer them cash, right? So
Yeah.
like you're just prohibited from
Hmm.
not going through your primary care doctor. And if according to them the manual says that no, this falls outside of the scope of what the government will reimburse, well, tough luck, you're not seeing a specialist.
Interesting. This makes me think about like holes in my beautiful plan, but like the idea of that we have two systems of getting insurance. Now, the exchanges are actually quite small. I think it was around 11 million was
Mm.
what they're quite small compared to the behemoth that is the employer sponsored market. But I could see something like this working where we could have plans that restricted choice and people would voluntarily be fine with that, right? We sort of
Right.
have that in the sense of we have HMOs and PPOs. So I have some published work looking at within Medicare. Actually, this wasn't in Medicare Advantage, but it applies to Medicare Advantage. That when you have the HMOs and PPOs, what they do is they set up networks that controls costs because they're going to pre-arrange prices with providers with the carrot of if you agree to our price, you get our whole plan on the preferred network. If you don't, too bad, you're not going to get anyone in the preferred network.
Right.
So that's supposed to control costs, but it's true that it's adding restrictions, and so people that don't mind that are healthier people. So in my research, we looked at sorting among kinds of plans, and definitely the HMO PPOs were more likely to get the healthy people because they don't mind restrictions. So if you could think about having these plans in the choice set that were more restrictive, but also cheaper, we could see people switching into them, and that would be great. The problem with the health exchange is that it's with the employer sponsored and the health exchange is that these are both markets with the same kind of mix of people,
Mm.
right? So if I wanted that kind of plan, I'm not in that market. I'm in the employer market. And yet in the employer market, I can only choose from the plan that has to fit everyone in my employer. Or if I'm a sick person, right? I can only have I have to choose I have to be put on the same plan as the really healthy people who would prefer the bare bones plans. So one problem with choice is even if we opened it up, the two populations are not separate in their health conditions. They're both equally sick and healthy.
Mhm.
And if we wanted to make these plans on the exchanges, the people that were sick but just weren't lucky enough to have an employer plan
Yeah.
could be in trouble.
But I do generally like the idea of taking the exchanges and using them to create more of
Mm.
a market, right? Very often Republicans just have this kind of like political whiplash of they couldn't repeal it, they couldn't replace it, and I'm thinking just take it and actually like I mean like and that's not just to Republicans, it's also to like moderate Democrats that like
Hmm.
believe in like some kind of market principles that let's just take the exchanges and actually make a market like what it's actually called.
Yeah, how could we use something that's already set up?
Yeah.
They didn't totally fall apart as predicted. There were enough people that found it valuable. I mean, well, subsidizing 90% probably helped,
Right.
but there's some functioning, we've learned some lessons. How could it be used to enhance the choices that exist?
Are there any parting thoughts that you'd like to give to our audience when it comes to the words for the whys of healthcare and
Hmm.
perhaps some better ways of people channeling their frustrations?
Yeah, always come over and let me know your frustrations because I love answering whys. Um, yeah, I just would encourage people to still to think about the system and what could be different, like the idea of the patients that we talked about, that patient relationship with the insurer, examining the system we have and asking why, but then like why not something else? So why do we have a relationship where I only pay the insurer? My only job is to hand over money. That's crazy. And thinking, looking around the world, how we can notice things, don't take things for granted that because it's set up like that, that actually is an optimal choice.
Right. I mean, and it goes a little bit back to my original story. Like when I'm like reading these explanation of benefits, I'm thinking, why can't I work more with the insurer so that like they can empower me to help them save money, which will then in the long term save me money.
I feel like people in innovative spaces are like just charged up right now with it with AI, and I want to put a call out to all the innovators that if you see these moments, right, where there's some people who really wish they could pay for innovation and health, like, and they're just waiting for someone to come up and show it to them.
Right.
But the other example besides concierge care is direct primary care, which is just for primary care, but it's the same kind of model. You pay a fixed fee and they promise to take care of you for some predictable set of things that you would need. You need to take your kid to get their vaccines and you have these predictable things you need from a primary care provider. So that seems great and you could shop around and like they often have telehealth, right? But the problem is it exists in the system that doesn't, I'm still going to need some acute insurance and there's nowhere else in the system to take care of the other piece.
Right.
So my call is out to innovators, like keep iterating on these pieces because there are people out there that want to join you in it.
Right. I think that's an excellent point to end on. And with that, I would like to thank our audience and till next time.
Thank you for having me.
To stay up to date, subscribe to our show from whatever podcast platform you're listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.